talk today is called The Incredulous Neglect of Infants in Pain and What We Can All Do to Help. And while, I appreciate that many of you are here today because you have children or grandchildren, I want to push the envelope a little. And I really do mean that some of the information in this talk, because it doesn't matter, as a member of society, and I think it's about a societal issue, I would like you to kind of take some of my words home and spread the word. So we're going to go onto a journey where I'm going to talk about pediatric pain. And I thought it would be neat if I sort of paralleled my own journey in pediatric pain to how you guys are going to go through some different thoughts and processes today. So when I was an undergrad at York, and I started at York, I knew that I wanted to understand and I wanted to research, as a graduate student, children who suffered. And I knew I wanted to do it in a medical context, so I was one of those, am I going to do clinical psych, am I going to do med school kind of students? And I decided on clinical psychology. And what I ended up doing is applying across the country and looking at different topics: cancer, mental health, things like depression, and pain. So when I signed up to be a researcher or a graduate student at the University of British Columbia, I knew that pain in children caused suffering, and that was why I was there. But what I wasn't prepared for is what happened to me in my first months as a graduate student. So as every diligent student, you have to do a literature review. You have to learn about the past so you can create to the future of a field. I never realized that in my lifetime, there was a belief in the medical system that infants did not experience pain. So much so that in my lifetime, they would do open heart surgery on infants without the benefit of anesthetics or analgesics because it was too dangerous. Side note, when you cut open a baby, they wriggle a lot. They don't feel pain, so they'll administer a paralytic drug, but not something to numb the pain or cut out the pain. And so I was hooked. At that point, early in my graduate career, I entered into this field that I knew was, I thought it was important, but it became my passion. And I wanted to pursue what I didn't know. And so over the course of the past 20 years that I've been working on this program of research, I've made this transition to knowing how much I don't know, but knowing that I need to act on what I do know. And this is what I want for you today. I want you to come here, having thought this is an interesting topic. I want you to believe that infant pain is important, whether you have children or not. And I want you to take that belief into action. And part of that action is spreading the word, because it's still happening today in your grandchildren's lifetime. So let's start with the bigger question. What is pain? So if you look at formal definitions, pain is a very complex subject. It relates to how we think, what we feel physically, what we feel emotionally, and also it takes into account the social context, the people around us when we experience pain. It is a sensory, emotional, cognitive, and social construct. So the world leaders are part of the International Association for the Study of Pain, and they describe that, and they get at that complexity by saying it's an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Self-report is an amazing thing as a scientist. Because when you ask, how many of you have been into a hospital or a doctor where they've asked you your pain rating on a scale of 0 to 10? Yeah. That is not just a simple number. What an amazing number that is. That number means, based in your life experiences, on what you've been told by your parents, by your spouses, by your children, what it felt when you experienced that needle or when you're experiencing that joint pain. That's what that is. And so as a clinician, so I'm also a health professional and a researcher, I can take that wonderful number that means a synthesis of all these different complicated factors, and I get a simple number that helps me understand. Self-report is critical to pain assessment and pain management. Describing it. What do we do with those that cannot speak? So again, side note, while I'm talking about infants, you can think about it and think about it in terms of the elderly who are demented, or children who have cognitive impairments, or other people who are just disempowered not to speak up. But I'm going to focus on infants. So what do we do? How do we study pain in infants when this number or this synthesis, this combination of all these varied factors, we can't get access? How do we do that? How do I do that as a scientist? How do I do that as a clinician? And I think what it helps to know is why. And I've written with a wonderful history student here at York, one of the things that I tracked when I became a professor is how. How is it that something like infant pain could be ignored into the 80s, the 90s, 2000s, 2017? I had gave a TEDx talk in 2015, and the cover of the New York Times was people holding down a baby while they're getting vaccinations from both sides and not even thinking about that support. That's 2015, and that's the New York Times. And some of the reasons people give is that, well, infants have no memory for pain. So one of the most painful things that an infant can go through, a healthy infant, let's go there, is circumcision. So if you ask anybody who's circumcised, hey, how much did that hurt you? How many adult males or teenage males or young child males could say, oh, it hurt a lot? That is not the right question to ask. We put memories in our brain based on how they got into our brain. Infants do not speak. Asking them to speak about their pain later in life is not how they would have encoded that pain. It's their bodies that remember. And so neuroscientists now are talking about things like central sensitization and wind-up, looking at neural signatures in the body, in the nervous system, that shows they remember. Their bodies remember. It's just we weren't asking the right question in the right way. They say infants don't have the neural structures for pain. Wrong. We learn at 19 weeks fetuses that there's connections, what we call nociceptive connections, into the precursors of the brain, this cortical plate. So what we use is the fancy word for pain perception, nociception. So nociception can occur, which means we can process pain from our peripheries, from our fingers and our toes, our legs, in our brain. And of course, another thing is, well, even if they do kind of feel the pain, they don't understand what it is. So it'll pass very quickly. And I want to say that these three myths are actually reasons why we should have, as society, actually believed that pain was worse. Imagine for yourselves if you were trapped in the moment and you had to experience a painful stimulation and not know that you've survived it before, that there will be an end for the pain in the future. You are trapped in the moment. Having no ability to travel in past, present, and future as an infant means that child does not know it's going to get better. That makes it worse for them. The idea that they have a developing brain actually also makes pain worse for them. As a pain teacher, when I teach medical students or nurses or clinical psychologists or physiotherapists, we talk about pain being a two-way street. Messages don't just come out from the edges of our body. They get shaped in here, and then we act based on that shaping. So getting a needle, getting yourself to a doctor's office to get to a needle, you say to yourself, it's going to be a few seconds. You'll get through it, and it'll be fine. And we call that modulating pain, using the brain. Infants are incapable of that. So what they're doing is getting a barrage of noxious stimulation from their peripheries or from pieces of their body with no ability to think it through and to help moderate those pain responses or enact any behaviors that would help them engage in pain management. And then the final thing about infants do not understand pain and why we should have paid more attention to infant pain or why we should continue is because pain doesn't require understanding. When you put your hand on a hot stove, do you need to understand the biology and the physics of what is going on? The fact that they don't understand pain and that they were born, that human beings are born signaling pain, no one has to teach that. They come out and they're crying because they're experiencing distress. That innate ability should have told us that infant pain is more important, perhaps, because they're not even able to process anything. And that reflex, which doesn't use the brain, tells us that they're experiencing pain. So armed with facing these myths 20 years ago, and that have been in our society since time immemorial, I started the Ouch Lab at York. And so I like to put up our logo because one thing I want you to understand is infants are different than any other stage in the lifespan. Understanding an infant in pain, I think it is required that you understand the caregiver and the social construct. So the O is actually supposed to be two arms. The first arm representing the family context, and the larger arm, the societal context. So all of you in this room need to be arms around the child in pain. And so when I was starting out at York, I wanted to actually start in the neonatal intensive care unit and work with infants who, if you've ever walked through, has anybody ever walked through a neonatal intensive care unit? Yes. I'm glad not so many. There is few things on this planet and few experiences as inundating with pain as a NICU. And we call it iatrogenic pain. It's pain because we have to do this to save their life. But what I realized is that before I could dive into that, I needed to understand the normal state of affairs. I needed to understand how pain developed in the context of these arms before I could go into an abnormal context, a context that not everybody faces, to understand how pain processing. And that's how I started the Ouch cohort. And thanks to the support of York and the Tri-Councils and a lot of different people have, and the Canada Foundation for Innovation, it's been a fantastic opportunity, and we are actually the home to the largest cohort in the world, looking at the development of infant pain responses in the context of the caregiver. So the research and some of the points that I'd like you to be able to tweet about, talk about, share, are actually coming from the largest study that has been done to date. So, how do I measure infants in pain? So I've talked to you as members of society, I've talked to you as people who could interact with infants. But as a scientist, I can't ask a baby how much did that hurt. So what do we do? So infants in pain, how scientists address infants in pain is by coding. So we watch videos of their facial activity, their body movements, and their crying. And we actually derive a 10-point scale as well, because nurses and physicians who are working in NICUs use this as well in some way. So you're looking at their facial activity, their body movements, and their crying. But I learned very quickly. So, we were involved with over 2,000 vaccination appointments. And so what I realized is that there is a lot of variability in how infants express pain. That means there are a lot of different ways babies express pain. This is a dangerous thing because medical science right now isn't very well equipped to handle variability. When we look at, does a pain medication work? We use something called a randomized controlled trial. But what that means is we randomly assign a group of babies to a treatment and to a control. We take their pain responses and we average it into one score, and then we compare those two scores. So we compare an average pain score for people who've gotten the treatment to an average pain score to people who don't get the treatment. And what we learned, because everybody thinks, well, babies just scream and there's no difference, is that there was so much variability that using those average pain scores means we are over or underestimating 100% of babies. So this was our first kind of breakthrough paper in terms of calling to question how we can do this. Do we think the variability, and I do think the variability is likely greater in infancy. So when we check to see, does a drug work, or does a non-pharmacological, or an intervention that does not use drugs works for a baby, they're summarizing over babies that are 50% of babies just stay stressed over the first 2 minutes post-vaccination. 20% of babies really get stressed out at first, and then they regulate and kind of come down. And then there are some babies that freak out, and then they calm down very regularly. Imagine having one score to describe those 3 babies' pain responses. That's what's happening right now. Well, like I said, the arms around the infant are just as important. And so another thing that we started tracking over this large cohort was that what does a caregiver say it is? I would hesitate to say, and I wouldn't hesitate to say, that parents are experts on their child. And so we wanted to ask them how much pain you thought your child was in after vaccinations. And we've always tracked that over time. Our second kind of what we call breakthrough papers, because I have these findings that because of the large sample size, we really want to mobilize. So what we found is that when you ask a parent how much pain their child is in, I thought we would be able to predict it by their body movements, their cry, and their facial activity, right? So parent says the baby has a 9 out of 10 pain. I have measures of the baby's body movements, which are gold standards. They should have a high correlation. They should relate. Guess what? They don't. So in the pilot study, and this was actually part of a study that helped us get the millions to do this large study, what we found was that when we called mothers back after their vaccination appointment, so we said, do you remember that vaccination appointment, which we had all the videos for? How much pain was your child in during that appointment? Because we know that when parents interact with the healthcare system, they're always recalling. Like they're thinking about, oh, last night the kid was in so much pain. So we were very interested in their pain memory for that. I could predict a mother's pain recall with their level of mental health psychopathology and their level of cultural stress more than the infant's actual pain behavior. It makes sense. We see the world through our lens, and so when mothers are stressed, things get more stressful. When mothers are not stressed, they don't see it as threatening. But the challenge is that there is this child that actually is experiencing pain that may not be so up to interpretation. Because my belief is that when you do a painful medical procedure to a child, you have no choice to think that it's in pain or not. If it hurts you, it hurts them. And I think that's the rule of thumb that I will not compromise on. If it hurts you, it hurts them. So the next kind of take home, and the next sort of thing we did is that you can imagine with all this data, we wanted to predict child pain responding. So it was ultimately at the end of the first year of life. So this OUCH cohort that I'm talking about, we're actually now following them, and our kids are 10 years of age. So we've been in this for about a decade. But we wanted to take that first year of life. We looked at them at 2 months, 4 months, 6 months, and 12 months. And I wanted to predict, using caregiver factors, which kids express the most pain at the end of the term. And we looked at baby factors, and we looked at parent factors. So bear with me. The real model looks way worse, I promise you. There are no pretty pictures, just a lot of lines and arrows. But the take-home message from that paper was that you take a child's, when they first come into their vaccination. So at 2 months, they haven't had a lot of experience with pain. They haven't had a lot of experience with their caregiver. And children who have higher reactivity from the get-go, then they go for that is moderated by how quickly they calm down. And so that's a picture of peace. And so we call that regulation. So you have a child, for example, that has high pain reactivity, but doesn't learn to calm down well. And you have that with a caregiver who may be less sensitive to that painful response or more sensitive. So it can go in either direction. But it's that combination of how they came out of the womb experiencing pain, right? 2 months, so not pretty naive. The combination of how they learn from their parent for different reasons, but we call it sensitivity, over those first 6 months that then predict infant distress at 12 months. So what this established for the first time is the importance of what parents are doing. It's not just, pain responding isn't just because you have a sensitive baby. You can have a sensitive baby, but if you learn how to help them regulate or calm down over time, that will change outcomes at 12 months. The benefit of having a cohort is that we can keep following them. And we have been so blessed that this cohort has stayed engaged, because this is an intensive study. Imagine having a researcher follow you for 10 years. And so we're always so grateful to the patients and families that have made this happen. So we wanted to go to preschool. And that's the next important vaccination. So any of you who have grandchildren or children would know that they have to be vaccinated before they can get into school. And so preschool is also a very predictive time for future school outcomes. And so I wanted to look at what was predicting not only fear, who are the kids that are freaking out before the needle, and who are the kids that are not. So I wanted to focus on fear first, because now we were older. Our children were 5. Children can report fear, where at 12 months they couldn't. And so I was first interested in who are the kids. And I want to give you an opportunity to see what I see. So I'm going to show you some clips right now of what I see as a researcher. I ask if you know these families, if you could just come to me quietly at the end of the talk and we'll just chat. And if you don't, no worries. So it was really important for us to predict who were the kids that had more fear. And we were a little shocked. Because what I found, my program of research is that I'll do the same thing. I'll be invited to write a chapter. So I'll write a chapter on my hypotheses, they'll ask me my opinions, I'll publish it in some international book, Oxford's textbooks, things like that. And then my research shows how wrong I am. And all my wrong hypotheses get to be published for time immemorial. And this was one of them. So we thought, if you didn't manage their pain well and you had high pain reactivity throughout, the kids would remember that, and that would cause more fear. What we actually found was that the amount of pain at the 2-month vaccination, for example, predicting forward to fear before the preschool, actually didn't predict. And we have a huge sample size. So we were kind of head scratching when we were putting together these models to figure out what happened. What was the most powerful predictor of who was scared? Parents. Not just parents' behaviors at that preschool vaccination, but if you can imagine how crazy it is, we took a 5-minute snippet of how they soothed their baby prior to needle at 2 months and 12 months, and we were able to predict fear. So the hypothesis, I made that, those arms around my baby and my logo, was even stronger. I wish I made them bolder. Because what we're realizing is over those first years of life, because children are still developing so much, it's hard to predict. So, it's the same reason why we can't predict a lot from infant intelligence, because they're changing. And if they're hungry, that means a lot to them. It may not mean as much to a high school student, but a hungry baby is out. You're not going to get any testing. And so what we think this reflects is that infant behavior still isn't cast in stone. Right? They're still changing. They're still very influenced by, an itchy diaper or things like that may not help us predict from that. But parent behavior has always, in all of our 21 papers that we have done on the OUCH cohort, have shown over and over again about how stable they are and how powerful they are. So we move from fear to pain. What predicts kids? We're going to now express more pain, because that was about fear. And so we have a paper that is actually going to be the subject of a press release really soon. The journal has decided to do a double media push. So we're going to have a media push now in the next, I'd say, 3 weeks. And then there'll be a media push in February. So when you hear about something about vaccination pain, that will be this study. And you guys are getting open access to something that should be hitting the news in between 1 and 4 months from now. The take-home message, after 10 years of analysis and trying to figure this all out, is that when we look at what predicts the most pain afterwards, it's parents not only doing good things, because we can teach them good things to do, but they actually have to not do bad things. It's that combination. So when you actually just look at what we call coping promoting behaviors, holding them close, talking, trying to distract them, the things that you watched Lily's mom do, right? Just what Lily's mom. We actually found that if we just look at that, the more a mother, I say mother, but we had about 8% of fathers in this sample. Most of the time, mothers are bringing them. So my apologies to the dad in the room. But when we looked at that relationship, what we found is that actually saying things like take a deep breath and helping them cope, parents who did that actually had babies or preschoolers who expressed more pain. And we're like, what? But the advantage of doing large sample studies and the importance of doing large sample studies is that we look at it multiple variables at the same time. So we got a very different picture. So let me walk you through, and this is just kind of one of 15 model of paths in this, but I think it's the most important. And what we see is that it's not just about coping promoting. It's about doing less distress promoting. So we've had parents say things, an example of a distress promoting comment or comment in our study would be, you're upsetting mommy, don't do this. Or saying something like, good girls don't act like this, you're better than this, it doesn't hurt that much. And you criticize the child. Or another bad thing you could do, like these bad, I just use the term bad, there are no bad parents, they're just behaviors. But with this idea saying something like, if you do this, you're gonna make mommy very mad. Or on the opposite, I'm so sorry, I'm so sorry, I'm so sorry, I'm so sorry you're going through this. And you keep apologizing over and over again for the child. That actually increases distress. But what we found is that this combination of doing a lot more, doing coping promoting and not doing distress promoting, it's even stronger relationships, to not doing these distress promoting will cause children to then be less distressed. And it's their less distress, being less distressed earlier in the appointment, that predicts them being less distressed at the end of the appointment. So this whole idea is that ultimately, throughout the entire appointment, and we had different pathways to sort of show this, but taking it all together, what we feel that is critical is that parents throughout the appointment, even before the needle, work towards doing taking coping promoting statements. And on top of that, don't do things like apologize or criticizing their child. It's the combo. Because if you just do the one, that doesn't do it. It's the combination of doing, and I think I can go back just to say it again, doing good and not doing bad that results in less coping outcomes. So what can we do? So we're coming to the last section of the talk. I'm hoping you've transitioned from this is an interesting topic to understanding that this is an important topic that requires not just parents and grandparents, but all of society to acknowledge. And I've been very fortunate. So the cohort has given me some people have gotten to know our study, and we've set norms that have never existed before in the world. And that's caused some really great invitations. And so I've been really pleased to kind of work on these two projects. One is a Cochrane review. The other one is the Canadian Medical Association Journal, and I got to be a clinical lead on that project. And our work combined has now been picked up by the World Health Organization about vaccinations around the world. So in 300 dense pages, I can tell you what should be done that our team has put together in 300 pages, dense tables, lots of detail about what circumstances will reduce pain in infants, children, and adults around the world. I'm not sure how many people, I don't have time to even read back the 300 pages. So I knew we needed something more accessible. And so what I came up with is across all my research, and it's kind of weird to summarize 10 years of research with 4 letters, but here's my try, is the ABCDs of pain management. And this is something that I think anybody could spread. And it's the idea that you look at the A and the B, and it's about the caregiver. Assess your own anxiety. Belly breathe. Just to focus yourself in the moment. Because when you're stressed, nonverbal infants pick up on that more. I always say, think about what happens when you hold a newborn infant or a 2-month-old going in for the vaccination. Where's their head? On the heart. What do you think they're hearing if a mother is stressed or a father is stressed? A really fast heartbeat. I can speed up your heartbeat sitting in this room at your age with all the cognitive capacity in the world, and I can speed up your heartbeat if I put a fast heartbeat here. So imagine what that does to an infant. Knowing that you're assessing your own anxiety and being able to calm down is really important. And then what do you do with the child itself? And the C and the D are about what you do with the child. Bring them close into a calm, close cuddle. My research also has expanded into attachment research. And I think for those of you who were in Dr. Backer's talk, the primacy of the caregiver relationship with infancy, I think, has long-ranging, outside of just pain. And my research is actually expanding beyond pain, because what we watched in these quick snippets were so predictive that we want to actually expand what we're predicting, and not just pain and anxiety, but school outcomes. Because what this is at the heart of is negative affect regulation. To succeed in life, you gotta get a grip, right? People who can stay calm when things get stressful are people who can succeed. When you can't calm yourself down, your frontal lobe, I tell my daughters, your frontal lobe shuts off. I can't deal with you right now. And so, bringing them in, teaching them at 7 and 9 and all the way through, calm down first. Come for a cuddle and I'll listen. But no matter whether it's pain or not, let me calm you down. And then let's try and figure this out. Let's problem solve with our frontal lobe open. So that calm, close cuddle is the beginning in infancy of self-regulation. We are hardwired. We are hardwired. We are born signaling an adult to come close. We may not know anything about what pain is, what it means, when it'll stop, but what we do know how to do coming out of the womb is to cry. We know that this is distressing, we can't cope on our own, and we signal. And so that calm, close cuddle, which comes from an attachment perspective, I think is critical in the early years to helping them regulate distress. And the final thing is distraction. Distraction is a little tricky because you can't distract a high distressed infant. And so you actually have to wait, hold them in the calm, close cuddle until that peak freak out, that's what I call it to tell parents, that peak distress has calmed down a little, where they're breathing a little more. If you've ever seen an infant who's gotten a vaccination or any painful procedure, they literally stop breathing. And young children do that a lot, where when they've hurt themselves, you hear a crash. I don't know if parents can identify. You hear a crash and you hear nothing. And it makes you panic because you're like, oh no. And it's often they're catching their breath. And because pain takes their breath away. And so once you've kind of gotten past that initial high distress, it's time to engage them in distraction. Let's get them out of this now. So the idea isn't to keep saying, oh, it's okay, come, we'll do this. It's like, okay, I know this hurt. I'm acknowledging your pain. Now, when are we gonna get that ice cream I promised you after the needle? And trying to get them to move along. But if they get high distressed again, you go back to C and do the calm, close cuddle. When you don't believe, as a parent, a grandparent, or a member of society, children and infants in particular will continue to construct pain in a threatening environment that will exacerbate their pain response and change how they relate to the world. When you believe, the idea isn't to take away pain. Pain is necessary. Pain is evolutionary. Pain tells us to stop. Pain tells us to rest. Pain tells us we need help. But what we can do for infants who can't really process it on that level is allow them to experience painful procedures where we do want to try pharmacological strategies to reduce it as much as possible, but we want to set up a social context where when we believe that they feel, at the very least, supported through these painful procedures. Thank you so much.